receptors are highly expressed in lungs, heart, blood vessels, and GIT. And these are all this is the peculiar picture which shows how what are the pathophysiological things happening inside our body when the coronavirus enters. So let me be short in this area. Once the virus enters and it triggers a lot of cytokines storm, and also it makes the environment more thrombotic or more pro-thrombotic. So this is the problem for coronary artery disease patients, as well as even for a normal patients also. They may present um, uh, with a lot of vascular events such as DVT, pulmonary embolism, acute myocardial infarction because of the high thrombotic environment inside the body because of the COVID. The next slide will be the COVID-19 and the CVS manifestations. And so we can see all the acute coronary syndromes, type 1 MI. And what is type 2 MI is the supply demand mismatch, because the coronary arteries are normal. Still, the patient may get an MI. This is called type 2 MI. This is the supply demand mismatch, because the problem in COVID is the oxygen supply. If the oxygen supply is cut off, even with the heart with the normal coronary arteries will have a demand. So this is the supply demand mismatch which can cause the myocardial infarction. This is type 2 MI. And also other areas like myocarditis, Takotsubo cardiomyopathy, tachycardia, arrhythmias, and cardiac problems secondary to acute lung injury, DVT, pulmonary thromboembolisms, and arterial thrombi. These are all the other vascular manifestations of the COVID. Did coronary events come down during COVID period? Yeah, because there are the trigger events like physical stress, emotional stress. So a lot of discussions were going on. So during the corona period, we definitely had less amount of because we definitely had less number of patients presenting with COVID, with coronary artery disease. Because a lot of reasons were behind that, that not only suggest that the coronary artery disease is not reduced in incidence, but there are other reasons behind why the coronary artery disease or coronary interventions were less during the COVID days. We can see that the trigger events like physical stress, emotional stress of busy job life, air pollution, smoking are lesser during the COVID season, and trigger events like certain physiological, psychological stress or more, and poor access to the travel. The patients may have had an cardiac disease, but poor access to the travel. That is one of the reason that the patient might not have come to the OPD care. And also the paradox of bigger problems. It is the paradox of bigger problems and fear of getting infection in the hospital. A lot of patients were saying, you might have heard that a lot of general physicians were telling that because the patients were reluctant to come to the hospital because the hospital is treating the COVID patients and we may get exposed to COVID. So that's why they patients avoid the hospitals. That is also one reason where we didn't get too much of patients attending the hospital, and fear of not getting a proper treatment. So because the healthcare was stressed during COVID times, a lot of physicians and anesthetists were involved in the COVID care, and the specialty care had a scarcity of healthcare professionals, and absolutely transport delays were there in the COVID because of the restriction of movement. So this is one more slide, the COVID-19 and ACS. During this pandemic, patients with ischemic heart disease may not have a ischemic heart disease may not be infected with COVID-19, but still require critical care. Data suggests sharp decline of acute coronary syndrome admissions You can see relative reduction of 39.4% admissions in Australia and almost similar reduction in Italy. So, and you can see in Spain also, you can the number of diagnostic procedures in coronary in cardiac department fell by 56%, and PCA fell by 48%, and structural interventions fell by 81%, because the structural interventions are not going to be emergency, and we can expect such a fall is normal. And PCA in STEMI also was less than 40%. So up to 5% of the interventional cardiologists also had COVID. This is also a reason where we can see less number of procedures happen during COVID days. Possible causes for reduced admissions, like strict instructions to stay at home, as well as a fear of infection in medical facility, may prevent patients with ACS from reaching hospital. Maybe a change in the threshold for referring these patients for cardiac catheterization. Instead, they may opt for managing medically. So instead of sending the patient to cardiac catheterization laboratory or referring the patient to the cardiologist, many physicians might have thought like they can be managed medically for time being. The risk that healthcare professionals have in delivering acute care to the patients. And you can see the next slide will be the systematic approach of care of AMA patients during COVID-19 pandemic. So how to approach? It should be a systematic approach. The public to be assured of minimal exposure to coronavirus and get appropriate level of cardiac care that their presentation warrants, and use of PCI or fibrinolysis in patients with the ST segment elevation MI, and aim to avoid a reperfusion therapy for those with other causes of ST segment, because a lot of other causes are there for ST segment elevation, and maximize safety of medical personnel by appropriate masking of patients and using of PPEs. And a few other recommendations of care of AMA patients during corona pandemic. So from this part of the slides, I'll discuss how to manage patients with STEMI and how to manage the patients with STEMI. And finally, I'll conclude how overall management during this corona pandemic. The recommendation of care for acute myocardial infarction patients during the corona pandemic. All the STEMI patients should initially undergo evaluation in the emergency department. Patients should be evaluated in the emergency department prior to cath lab activation to ensure appropriate risks are assessed. All the patients require the placement of facial mask to prevent the droplet contamination of the cath lab and environment prior to the transport. Cath lab staff and physicians should have appropriate PPEs for safely performing the procedures, which includes all the gowns, gloves, N95, masks, and the number of healthcare workers present during the procedure should be limited, and whoever is essential should stay in the cath lab, others should leave. So recommendation of, again, it comes the patient with a respiratory compromise. If the patient comes with an MI and also with a respiratory compromise, it is better to electively intubate rather than going and getting stuck in the cath lab and emergency intubate the patient. This is also a recommendation from the universal bodies. And for all the procedures at risk of aerosolization, the PPR should be considered, PAPR should be considered. Proper PPE training should be done and practiced by the physician, staff nurse, because it is almost in the end of the period of corona. All might have learned about how to don and off the PPEs. So recommendation continued is the primary PCA should be the treatment of choice for STEMI. If primary PCA is not possible in a center capable of capable of having cath labs, so capable of handling the STEMI patients in cath lab, if for some reasons, if the primary PCA is delayed, so better to go for a fibrinolysis. If the patient reaches a hospital where there is no cath lab, go for fibrinolysis and refer the patient for a center for a cardiac catheterization, which in which a center where cath lab facilities is available, which is otherwise called pharmaco-invasive strategy. So principles of STEMI management, I'll go in detail. Primary PCA remains the reperfusion of choice, which I said now. And primary PCA pathways may be delayed during the pandemic up to 60 minutes, according to multiple experiments, because we have some door to balloon time of 30 minutes. So in those in the pre-corona periods, but as the delays up to 60 minutes are now allowed, and because of the logistic delays and also a lot of delays in the emergency department because of the COVID protocols. So if the target time cannot be met, or if there is a delay in the initiation of the cath lab procedures, then if the fibrinolysis is not contraindicated in such patient, in that patient, fibrinolysis will be considered in that patient. So STEMI management in COVID-19. So if the diagnostic kit for the COVID is not immediately available in STEMI, is now not available, because if you take a sample next day only we'll get the results. But still we can screen the patients for CT lung involvement so that we can be protective. And still the cath lab procedures will be done with the PPE on, and once the procedure is over, he or she will be patient will be shifted to the CCU isolated area, and he or she should be taken care till the COVID reports come. Till then, we have to consider every patient as a COVID patient and do all the precautionary measures, and do put PPEs before handling every patient. So the consider immediate complete revascularization. If you do a coronary angiogram and do an angiogram, and you are seeing multiple lesions, or if you want to put one or two stents, like if the culprit artery is LAD and there is a tight lesion in the other arteries, so normally we do a culprit revascularization, and we do a staged procedure for the other involved artery. But now what they are telling is they do complete revascularization instead of going for a staged procedures. So all physicians involved in the management of patients with the STEMI should be familiar with indications, contraindications, and dosage of fibrinolysis, and adhere to established administration protocol. This is the tabular column. We can very well see the STEMI. If the patient comes to a hospital where there is a cath lab, then go for primary PCA. Where there is a cath lab but there is a delay, then go for, if there is a delay, then go for a fibrinolysis. If the patient reaches a hospital without a cath lab service, go for fibrinolysis. If we are able to transfer the patient to a cath lab setting within less than 60 minutes, then we can directly transfer the patient, or otherwise go for fibrinolysis. So so far I have managed to talk about the management of STEMI in COVID-19 pandemic, and I am just entering into my second part, that is the management of NSTEMI in COVID-19 pandemic. So NSTEMI patients, although they are not myocardial infarct patients, but still they are at high risk of developing into going into a myocardial infarct if not treated properly. So they can be categorized into 4 groups, like very high risk group, high risk, intermediate risk, and low risk. How we can categorize, like, so we have a gray score. So to categorize that NSTEMI into high risk or low risk, and that so we can always we can always go clinically also. If the patient has a high heart rate, cardiac failure, if the BP is low, cardiogenic shock, then immediately we have to plan for a PCA. So issues requiring special attention of ACS management. So what are the issues? Like a myocardial injury and acute myocarditis due to COVID-19 infection itself. This is a viral myocarditis, can mimic acute coronary syndrome. So all might have had experience that the patient will come to the hospital and for a vague chest pain, and troponin will be done for that patient, and the troponin will be raised. So immediately we think that it should be an ACS. May not be an ACS, because the COVID-19 can directly affect the heart and cause myocarditis, which in turn raises the troponins. So mere rise of troponin does not signify that it is a ACS. It may also be a myocarditis. So rapid antibody detection kit can reduce the time delay, and may be useful or helpful for quick triage of COVID-19 positivity in ACS. And in every city, we have to plan a few CCAs dedicated to COVID patients and few cath labs dedicated to COVID patients, so that all the patients can be referred to the same hospital. So issues which require special attention for ACS management during COVID-19 pandemic continued. It is delayed presenters of STEMI will significantly increase due to the lack of proper transport, lack of routine medical services, reluctance to attend the hospital in the present condition, and fear of getting infection from healthcare system. This we already discussed. Even in a hospital equipped with cath lab, stipulated door to balloon time for primary PCA may not be maintained due to the delay in ruling out COVID diagnosis. So thrombolysis is preferred even in patients with hospitals with cath lab if the procedures are delayed for shifting the patient to cath lab. So the next will be the issues which require special attention will be the anticoagulant dosing here. So because we use antiviral drugs for this COVID pandemic like lopinavir or ritonavir, may need dose reductions or avoidance of CYP3A4 mediated drugs such as rivaroxaban and apixaban. So lopinavir and ritonavir, though through CYP3A4 inhibition, causes increased serum concentration of ticagrelor. Ticagrelor is a common antiplatelet we use for PCA patients. So it should be ticagrelor should be discouraged if the patient is undergoing treatment with antiviral agents. So it should be discouraged due to excess bleeding risk. Conversely, if you want to use a clopidogrel, it may not also provide sufficient platelet inhibition during concomitant administration of lopinavir or ritonavir. So we have to balance according to the situation and according to the condition of the patient. So the next issue will be the co-administration of lopinavir or ritonavir with the statins. If always the statins also use the same pathway for metabolism, so statin metabolism will be delayed. So the patient with the taking statin on taking antivirals like this may end up with myopathy. So, and also other QT prolonging drugs like hydroxychloroquine is also we should use cautiously in this type of ACS patient, like azithromycin also we should be cautious in using this. So we can, this is a table or a chart which shows what are the drugs to be used for thrombolysis in patients with STEMI. We can use streptokinase, altiplase, reteplase, and tenecteplase. These are all the doses and recommendation, which is not much different from the doses which were used in the pre-COVID seasons. So same thing, aspirin, clopidogrel, everything is same. Enoxaparin and fractionated heparin, everything are in the same dosage group only. And so coming to the robotic PCA or CORPATH, so the recent advances in the cardiology is one is the robotic PCA. So the operator can be outside and can manage the cath lab procedures and can be done robotically, and so that the healthcare workers are not getting exposed if the patient is having a COVID. So this causes the less radiation for cardiologists and away from the infected patients, less radiation for the patient, precise, these are all the other precise stent lengthening, these are all the other advantages of robotic PCA. So this is one important slide. We can see there is a potential interaction of drugs used in COVID-19. So if the patient is using chloroquine or hydroxychloroquine, always see to the drugs which is like a beta blocker or QT prolonging drugs. So we need to monitor ECG in those patients. If the patient, COVID patient, is using methylprednisolone, the caution should be with the patient. If the patient is taking warfarin, statins, we need to monitor INR. And so if the statin is used, it should be dose should be reduced. So antiretroviral drugs like it may interact with warfarin, statins, novel anticoagulants, antiarrhythmics. So if the antiretroviral drugs are used, if the patient is using these type of the drugs, we should avoid or reduce the dose in those patients. So here, so we can see, consider how to manage the QT prolongation, QT correction in these patients. If so, this is an important slide where how you can manage QT prolongation if if a patient wants, if the patient warrants the use of drugs which can prolong the QT. So this tabular column might be confusing, but I can tell you very simply and precisely. If the patient doesn't have an ECG, we always ask the patient to take an ECG. This is one recommendation. And if you see the ECG and if there is no QT prolongation in the baseline ECG, and ask the patient to go ahead with the drugs which can prolong the QTC. And once you initiate the dose, after 1 day or 2 doses of COVID drugs, then you repeat the ECG again. If the still the QT prolongation is no, there is no QT prolongation, you need not repeat the ECG again. If there is an issue with the QT prolongation or QRS duration or a QT prolongation, then we have to be very cautious, and we need to monitor. Cardiac monitoring should be advised to that patient. So in summary, I can, before concluding, I am just doing a summary workup. We are amid of a pandemic of unprecedented magnitude. This has overwhelmed the medical infrastructure worldwide and compelled to make modifications in the management of commonly occurring diseases. In case of ACS, individuals should be educated to seek medical help immediately if experiencing symptoms such as chest pain. There may be a need for PCA procedures to be minimized in order to conserve the health resources and limit the risk of infection and its transmission among healthcare personnel. Intervention should be in the cath lab if proper PP is available, and in an institute with the proper infection control unit. Conservative approach can be recommended for all ACS patients who are stable. Fibrinolysis may be considered as a reasonable option. So in concluding, these are changing times in the landscape of medical practice. Coronary events, the largest killer, continue in corona times. Public education important to disseminate availability of medical care. Teleconsultation has a vital role. Medical personnel need to be vigilant and protect themselves and their families. All emergencies should be dealt with as per best practices with PP use. Robotic angioplasties have a greater role in minimizing exposure to the number of personnel, especially vulnerable personnel. So with this, I'm ending my show, and if there are any questions, I am eager to answer in the stipulated time.
Okay, sir. So shall we wait for few minutes for questions?
Yeah, definitely. I can wait for a few minutes for questions. If there
Okay,
are
sir.
any
Fine.
questions, I can answer.
Okay, sir. Fine. So I think there are no questions. So shall we wait or wind up, sir?
Yeah, we can wind up.
Okay, sir. So
Thank you.
on
Thank you so much.
okay, sir. So on behalf of the organizer, we would like to thank you so much for your insightful and educative talk, sir. Thank you so much, sir.
Thank you. Thank you. Thank you.
And from here, I am ending the session now.
Sure. Sure.
Okay, sir. Thank you so
Thank you.
much.
Thank you.